Yeah, I think some of the most one of the most important pieces of information we need is really to strengthen this link between the measures of microbiome disruption or dysbiosis, the measures of colonization and pathogen load, with the outcomes of transmission and infection. Link those more strongly. We have pretty good observational data showing this cascade in this sequence, but what we really need is some experimental data, in human experimental data. And one way to do that would be to introduce some interventions. One could be microbiome sparing antibiotics. Introduce them in a population and compare that population to another population and take some measurements while you're doing it and see those associations. Well, in shorter summary, it's potential new regulatory and payment models. In terms of potential new regulatory models, we need to figure out how to integrate microbiome indices, bioindicators, if you will, biomarkers of antibiotic-mediated dysbiosis, colonization, and then pathogen load with the clinical outcomes, and integrate those into approvals that reflect, for the sake of microbiome-sparing antibiotics, reflect perhaps co-primary endpoints, along with equivalency in treatment of the primary infection, which is the antibiotic is going after, benefits in these microbiome indices, and in a way that those microbiome indices mean something, or there's good likelihood they translate into clinical outcomes. And the second is new payment models, and that really means something different. When we think about new antibiotic development, we say, oh, we'll develop a new antibiotic and then put it on the shelf for when we need it. That's just the opposite here. These microbiome-sparing antibiotics are antibiotics designed to favor evolution away from resistance. And so where we are trying to prevent resistance by a new type of therapy, they should be widely used, not put on the shelf. They should be widely adopted. The two could fuse, though. The potential new regulatory pathways could fuse with innovative payers stepping up also to look for population and payer benefit in the use of these microbiome-sparing antibiotics. And some of the evidence that links the bioindicators or biomarkers with the clinical outcomes could also be garnered through trial population use of these new drugs once they have gotten FDA approval for their primary indication of treatment, maybe along with those co-primaries of better microbiome markers.